after the conference is done.
Everyone's good? Hello there. Welcome to today's presentation on promoting COVID vaccines in the Hindu Cultural Center here in Winnipeg. I'd like to thank everyone in attendance and everyone on Zoom who's joining us today. My name is Dr. Soubhik, and on behalf of Sanskriti, the Bengali Cultural Association of Manitoba, and the Greencrest Clinic, I'd like to welcome you all today to our presentation. The purpose of our presentation today is to talk about COVID vaccines, COVID, and trying to promote the vaccinations within the community. Not just within the East Indian community, but the community at large as well. We hope to tackle some of the myths about COVID vaccines and COVID and try and promote vaccinations for everybody. With that in mind, our guest presenters today are Dr. Chakraborty, who is a part of the Department of Veterinary Medicine at the University of Manitoba. Myself, Dr. Soubhik, I'm a family doctor over at the Greencrest Clinic. Dr. Kawshik, who is a pharmacist and pharmacologist at the Atlantic Medical Center, and our guest speaker, Dr. Anand Kumar, who is a professor at the University of Manitoba in the Department of Medicine, Department of Pharmacology and Therapeutics, as well as a critical care physician and infectious disease physician as well. With that in mind, I'd like to start off with Dr. Kumar.
So much. It's a great pleasure to be here. I'm really pleased to be able to present to my own community here, and I hope that this will help get that small proportion of us who are still unvaccinated vaccinated. Actually, the Indian community is doing quite well by and large in that area, but there are pockets where vaccination still lags. So what I'm going to do today is I'm going to review to a great extent how we got here, and I'm going to tell you where we stand as far as vaccination goes, particularly in comparison to some of the other communities. So you guys have all at least some familiarity with the COVID-19 timeline. You remember back in January of 2020, the World Health Organization announced a mysterious coronavirus related pneumonia in Wuhan, China. 59 cases, travel precautions were implemented. There were actually reports of this for those of us who are kind of have our ear to the ground on this kind of thing, actually back in late October, November of 2019. But it didn't become kind of an official thing until January 21st. The CDC in the United States confirmed the first US coronavirus case. Washington State resident became the first person in the United States with a confirmed case coronavirus having returned from Wuhan. January 21st, the Chinese scientists confirmed that COVID-19, there was human transmission. Initially, it was unclear what was going on. They demonstrated that it was clear human-to-human transmission. At that point, it had killed 4 and infected more than 200. The World Health Organization at that point was still uncertain as to whether this was a major public health emergency. January 23, Wuhan was now under quarantine. 2 days, 13 more people died from that last report on January 21st, and another 300 were sick. 18 million people in the Wuhan area went into hard lockdown to try to get this under control. January 27th, we saw the first case in Canada. The person was returned again to Toronto from Wuhan. That person tested positive. January 31st, the WHO issued a global health emergency with a worldwide death toll at that point more than 200, and an exponential jump from 9,800, so almost 10,000 cases. It was finally declared a public health emergency, just the 6th time in its history that a global health emergency has been declared. Human-to-human transmission is quickly spreading at this point. It was now at that point they can see cases in the United States, Canada, Germany, Japan, Vietnam, and Taiwan. February 2nd, global air travel was restricted. February 10th, China's COVID-19 deaths exceeded those of the original SARS outbreak. Remember the original SARS outbreak, which shut down large parts of the world. About 500 cases total. By now they had 908 reported deaths compared to 774 with SARS. February 25th, CDC said that COVID was heading towards a pandemic situation. Pandemic, for those of you who don't know, is a worldwide epidemic. And what it requires is illness resulting in death, sustained person-to-person transmission, that is to say, essentially uncontrolled transmission between people, and worldwide spread. The CDC at that point said this was imminent. On March the 5th, the first case of community transmission in Canada was confirmed. This was in British Columbia on March 5th. By the end of March, all the Canadian provinces were in a state of emergency. And March 11th, finally, the World Health Organization declared that COVID-19 is a pandemic. It's the first pandemic that we've seen declared since H1N1 in 2000. A few other important time points. October 2020. So this is within about 6 months of it breaking out in a major way. The Alpha variant was first identified in England. The Alpha variant, this is the variant that caused our big wave in this last spring. That was twice as infectious as the original variant. In November of 2020, the first vaccine by Pfizer was approved. December 2020, the Delta variant, which was first identified in India, that swept through India and then Great Britain before reaching the United States and Canada. Delta variant is twice as infectious, and there's some suggestion that it may be more likely to cause disease or severe disease than the Alpha variant. So we're talking 3 to 4 times more infectious than the original variant. So a lot of the assumptions that we made with that original variant, where we said, it doesn't affect kids that much, it's not that easy to transmit. It does transmit, but it's not easy, not like measles. Those assumptions are out of the window. This is a much more infectious virus that we're seeing these days. And in fact, there are more variants that are emerging, some with increased vaccine escape potential. None of those are taking over yet, but for example, the South African variant is significantly more resistant to vaccination. And in fact, if you had one of the original variants, you could still get this South African variant. So there are new variants coming all the time. It's all really dependent on how many people in the world are getting the virus. And I can tell you, there are a lot of people getting the virus these days, still. Where does this come from? Well, the most likely source, the most likely reservoir for coronavirus is from bats, actually. It's believed the virus jumped from other species to humans through an intermediate host. So this intermediate host could be like a domestic food animal, a wild animal. They look at pangolins for a while, etc. But basically, we think they're coming from bats. It's not well known that coronaviruses are one of the most widely disseminated viruses, one of the oldest viruses in existence. In fact, you can find coronavirus variants in virtually every domestic or wild animal. Domestic animals, dogs, cats, sheep, pigs, horses, cows, you name it, chickens, any of those things, they all have their own coronaviruses. And as far as wild animals, as widely spread as blue whales, penguins, camels, any number, basically any animal they've looked in, any mammal or bird, they've actually found coronaviruses. Coronaviruses are large family of viruses. It's important to know that there are 4 known coronaviruses that cause respiratory illness in people already. That is to say, these viruses have been around for hundreds, if not thousands of years. They cause the common cold. About 40% of the common colds are caused by a coronavirus, similar to SARS-CoV-1 and 2. They also occasionally cause severe pneumonia, very similar to what coronavirus COVID-19 causes. They can cause illness in animals rarely. And, as I said, once in a while you can get animal coronaviruses that jump to humans and then spread through close contact. That's what happened in SARS, for example. That came from bats. And there's also MERS, which is Middle Eastern Respiratory Syndrome, that comes from camels. And those that intermittently jumped into humans started to spread. But we've been fortunate enough that we've been able to contain them. COVID-19 is a disease caused by SARS-CoV-2. So SARS-CoV-2 is the virus, COVID-19 is the disease. And this is a new virus that was first recognized in 2019. It's a novel coronavirus because it's never been seen in humans before. And because it's a novel virus, what that means is when it broke out, there was literally no one in the world who was immune to it, which means it's got a lot of people to look back. Now, what are variants? We spoke about them earlier. Basically, variants are mutations in the COVID. Mutations in the COVID-19 virus occur over time. They're expected, and these cause variant strains or mutant strains of COVID-19. We initially thought that COVID-19 or SARS-CoV-2 didn't mutate that much, not compared to something like influenza. Influenza is known to classically mutate a lot, and that's why it's different every year to year. It was thought that coronavirus is actually relatively stable, but what we didn't take into account is that mutation is related to the number of times it replicates. And when you have billions of people in the world that are getting infected, and each person has trillions of viruses, that means there are billions of trillions of opportunities for mutation to occur. And that's why we're seeing as many of these new variants as we are. It's not that coronavirus is intrinsically a high risk for mutations like influenza is. It's that it hits so widespread, affects so many people, that there are so many more opportunities for mutations to occur. Now, most of these mutations will kill the virus or weaken it or do nothing at all. But every now and then a mutation comes along that actually makes it more effective in terms of transmission, or alternately, more effective in terms of evading the immune response that you've had to coronavirus if you had it before, or to the vaccine. And either of those things gives it a survival advantage, and so those mutations, those variants start to take over. That's what Alpha did, that's what Delta did. Both of those viruses were stronger in terms of transmission than the previous viruses. Current studies, so fortunately, suggest that the effectiveness of currently authorized vaccines against these variants remains very good, and that's a really good piece of news. As I said, there are these new emerging variants. The first one that we actually saw was as early as September 2020. That was a variant emerged in Denmark related to meat farming. Then there have been these other mutations. I mentioned the one from South Africa that came up in 2020, December. January 2021, there was a new one in Japan that came from Brazil. Again, the mutation by and large involves the spike protein. The spike protein, I don't want to get into details of this, but the virus basically enters cells through basically a lock and key mechanism. So your cells have a lock on them, and to get into the cell, you need a key. And the spike protein that goes out of these viruses, in fact, let me show you, I'll go back for a minute, if I can. Just for interest here. See these viruses here, this is an electron microscopy of the virus. And what you can see, at least on this one here, for example, you can see these little areas where there's some whiteness there. These are spikes. These are actually little proteins that stick out of the cell. And that's basically the key. And so those attach to your cells, they find an appropriate lock, and by doing so, they can inject their material into the cell. So all of these variants that we're talking about basically alter that key a little bit, and that makes the key more effective. And that's actually what we do to immunize you too, and that's how you get immune. When you get infected, you basically develop antibodies to that key, and basically your antibodies glom onto that key and basically prevent it from going into the lock. And that's how immunization works, that's how natural immunity works. So how serious is COVID-19? Well, in most cases, particularly young, will settle down with rest and supportive measures, basically painkillers, fluids, and time. About, as a rough estimate, about 80% of people who get COVID-19 will actually settle down. About 20% will be seriously enough ill that they'll have to go to the hospital. About 5% of the total, 1 in 20, will end up in the ICU. And maybe about 2.5%, depending, will die. But that young lady over there, your chance of dying is extremely slim. You get to my kind of age, 60 plus, my chance of dying is probably more on the order of 5%. And as you get to 70, 80, 90, you get to other diseases, you can get up to 20% risk of death. So it really depends on which group is. However, all ages can require hospitalization and intensive care unit admissions. Some are at higher risk of getting severe disease. And those are seniors, as I mentioned. So basically anybody over 60 is at much higher risk, particularly over 80. And then with certain chronic health conditions that include pregnancy, which is going to be real important when we talk about vaccination, obesity, and any other organ-specific disease, renal failure, kidney failure, heart failure, COPD, cirrhosis, cancer, certain types of immunosuppression. All of those can have a very significant effect on your outcome. So, how have the different countries been doing in terms of COVID-19? So this is some interesting data on cumulative number of cases since they got to 10,000. So basically, in those countries where you had some progression, you say, okay, how have the different countries been in terms of control? Sadly, in fact, the United States has been by far the worst. India has not been great, probably the second worst. Brazil has been third in terms of the number of cases. That's where most of the cases are occurring. And although the United States is pretty bad, I'd actually suggest India and Brazil are probably worse because testing there is, of course, much less robust than it is in the United States and Canada. So if I had to guess, I would guess that India probably has the most cases. China probably has a lot more than they report as well. And then if you look at the number of deaths, it's fairly similar. Again, this time what you're seeing is that the United States is worst, and you see Brazil here, and then you see India. But again, I suspect for India and Brazil, the number of deaths are underreported as being related to COVID. We're going to see in the end what it really is down the road when they report total number of deaths and you compare it to the normal number of deaths for any given year. I suspect in India and Brazil, you're going to see a lot higher numbers than we're getting in terms of official cases. If you look at the breakdown in terms of, again, where cases are occurring that have been reported, overall, United States is number 1, India is number 2, Brazil is number 3, then you get into the UK, you get into Russia, Turkey, Canada is down here somewhere, and Great Park is where it's smaller. Let's look at the total number of cases. We have almost 250 million cases worldwide and 5 million deaths, right? So 5 million deaths, that's more deaths than we've seen in any other pandemic in modern history, apart from influenza in 2018. And remember, back in 2018, we didn't have oxygen, we didn't have vaccination, we didn't have modern hospital output support.
1900.
Sorry, in 1918, exactly, I'm sorry. What about Canada? Canada, we rank number 27 worldwide in terms of number of cases. We have had 1.7 million cases. Remember, the Canadian population is what, 35 million or so? Yes. We have a lot more people that are potential to get sick. And we've had about 28,000, 29,000 deaths. I will tell you that we're about average in terms of the per population type of thing. Had we actually done as well with COVID-19 as, say, New Zealand, we'd have only about 1,000 deaths. So although we've done average, there are countries that have done much, much better. And just for interest, India has reported almost, actually just over 34 million cases and about 500,000 deaths. But I think that's a gross underestimate. What are we seeing in Canada in terms of COVID cases when you look at the different populations? As you can see here in Manitoba in particular, I said we've seen about 1.7 million cases in Canada. Of those, about 60,000 or so were in Manitoba. And if you look at the number of deaths that we've seen, oh, sorry, you know, I'm going to skip forward a bit. Here we go. If you look at the number of deaths that we've seen, 1, 2, 3, 5. So we've had about 1,200 cases, 1,200 deaths in Manitoba so far. They're probably not as useful, I think, as, let me see, let's go backwards here.
Do we have the age group in that also, 12-35 deaths? Is it mainly on the group that you related most vulnerable?
Yeah, most of the deaths, most of the deaths are in the elderly. That's absolutely correct. But if people think that we don't see deaths in young people, they're sadly mistaken. I can tell you, I've been in the ICU. I was in the ICU for the entire month of September, And we had a lot of people in the ICU that are in their 30s, 40s, and 50s. In fact, the age range has shifted towards the younger people, in great part because the elderly, appropriately, started getting vaccinated. And vaccination rates in the elderly are actually really good right now. And so naturally the virus causes disease where it can't. Who has not been getting vaccinated? Young people who have been getting vaccinated. And even people up to 50 are not getting vaccinated because they're busy and they have other things and they think to themselves, oh, I'm not going to get sick. That's where we're starting to see the cases substantially, and seeing cases in even 20-year-olds as well. If you look at the breakdown of, this is the rates, rate of total cases of COVID per 100,000 population, you can see that we haven't been that bad yet. So compared to, for example, Alberta and Saskatchewan, our total number of cases is relatively smaller, and that's been a good thing. We're a little bit more than Ontario, a little bit less than Quebec, but look at the numbers here. They're like, these guys in the Atlantic provinces are about a quarter of what we are. That's why I'm saying that we could have done a lot better. But nonetheless, we're in the middle of the pack as far as the number of cases go. What about deaths, though? Sadly, that's, I think, somewhere where we fall down a little bit. This is the current rate of COVID deaths, and as bad as things are in BC and Alberta and Saskatchewan, you look at our total number of deaths adjusted for population, we are actually the second worst in Canada after Quebec. Okay, and that's because we did a really bad job with our last few waves, and although this time we haven't been hit that hard, we're still in a hole from our last waves when we really didn't do the right things in terms of shutting things down. Now I'm just going to touch base on a few things. One is, what kind of symptoms do you typically see with COVID-19? Now, my colleagues are going into detail, but I will just touch on this. Basically, depending on whether you have severe or non-severe disease, you can see that fever is the most common. Fever is the most common thing you're going to see. Cough, fatigue, shortness of breath. Shortness of breath you see in particular in people who are going to have severe disease. Okay? So if you have standard cold type symptoms, but no shortness of breath, hopefully you're going to have a mild course. But if you get shortness of breath, that's a sign that you're looking at potentially a severe disease course. More sputum production in that group. You also see, as I mentioned, shortness of breath. Dyspnea is another word for shortness of breath. Chills are more common, again, in people who have more severe disease. Myalgia, body aches. Essentially, I'm going to give it to you simple. If you have cold-like symptoms, cough, sneeze, fever, those kinds of things, you have cold-like symptoms, you're probably going to have a mild course. How many of you ever had influenza, actual influenza? You get the body aches, you get short of breath, your chest hurts. That's going to suggest that you're going to have a severe course potential. The one kind of unique thing about COVID-19 syndrome is a lot of people who can smell okay suddenly lose their sense of smell. And that's a very unusual thing, but it doesn't tell you it's going to be severe or not. But that's something that's kind of peculiar, somewhat peculiar at least, to COVID. Often occurs before you get a stuffy nose, actually. It happens fairly early. What do severe symptoms look like? As I mentioned, fever, cough, flu-like, basic flu-like symptoms, those are pretty common. But when you start getting shortness of breath, chest pain, coughing up blood, if somebody listens to your chest, the doctor listens and says, I hear crackles, and basically you just can't breathe, you're going to have a severe case. And if that's the case, and you go on and have a severe illness, then you're looking at potential things like pneumonia, COVID pneumonia, your lungs will completely white out. Normal x-ray, your chest, when you do an x-ray, your lungs are dark because the x-rays go right through, right? But if you have pneumonia, they get wet, they get full of fluid. X-ray doesn't go through, and it will look very white. You can get a related kind of injury called ARDS. You can get cardiac injury. They talk about myocarditis and pericarditis, cardiac involvement with some of the vaccines. You're much likely to get those syndromes from the actual infection than you are from the vaccine. 10 or 50-fold more likely to get it from the infection. You can have cardiac arrhythmias, septic shock, that's shock due to overwhelming infection, all sorts of liver dysfunction, acute kidney injury, multi-organ failure, and that's just the acute stuff. I haven't even mentioned the long-haul COVID, you know, the brain fog. We had one woman, you get direct brain involvement. We had one woman that I've taken care of that is having intractable seizures. She will not stop seizing, right? And this is something that's seen on occasion with that. So, if you do go down that severe disease course, what can we do for you? Well, what really, you know, brings people into the hospital by and large, yes, you get all these other complications, but the one thing that we see most commonly, the one thing that tells us somebody's going to be in trouble is they're short of breath, really short of breath. And some of you might have those home oximeters. So normally your oxygen saturation in your blood is like 95%. And typically we'll want you in the hospital if you're under about 92% if you're a normal person. And what we see is people coming in at 90, 88, 85, 80%, or even less. And those people are really, really sick. And so we do everything we can for those people. We use all the equipment you see at hand here. We have incubating, we've got oxygenation bags to oxygenate you. We have different ways to measure your oxygenation. We can give you supplemental oxygen. In fact, what we typically do is initially we'll give you oxygen by nasal pharmacy. So you know those tubes that kind of stick to your nose and they give you a little bit of flow of oxygen, tickles your nose a little bit. You probably have that after surgery a bunch of times. We can go up to about 6 liters of oxygen per minute. If that fails, we'll put you on a regular face mask. We can give you about 20 liters of oxygen per minute. If that fails, we can actually give you what we call high flow nasal oxygen. Locally it's called Optiflow, but we can give you 60 liters, 80 liters a minute of oxygen there. We've rarely had to go more than that in the past, but with COVID, we definitely see that. Next step after that is somewhere where you don't want to go. It's mechanical ventilation. We take a tube, we put it down your throat, we have to heavily sedate you. It's very uncomfortable. If not painful, we have to heavily sedate you, we'll give you narcotics, we put you on a breathing machine, and we have to pretty much make you unconscious for days or weeks. We've had people on this kind of machine for 6 to 8 weeks, and only then did it die, and some get better, okay? And if that fails and you're young, I just want to point out, we think this doesn't happen in children. It definitely happens in children, okay? There have been at least 20 kids that have gone through the intensive care unit in Winnipeg with life-threatening COVID. Okay, at least 20. And then if worse comes to worst, if we think you're a young person, you have a chance, what we can do is we can try to rest the lungs, and what we do is essentially, we basically don't let the lungs breathe at all. We don't make them do the work. What we do is we put tubes into your heart and into the major blood vessels in your groin, one in the artery, one in the vein, and we take the blood out of your body, we oxygenate it outside of the body, and then we put it back into your body. That's called ECMO. And the only other time that we typically use that is when we're on cardiopulmonary bypass for heart surgery. And again, we typically used to do that for a couple of days. We're seeing people with COVID-19 who we've had to have on this for weeks at a time. And again, a small portion of them survive. Really, this is something we restrict to relatively young people because you've got to be in really good physiologic shape to handle this. So, how have we approached COVID-19? Well, as you know, the initial response was all about what can we do without vaccines, right? So it's public health measures, basically flattening the curve. So typically, if you don't intervene with an epidemic and people continue their regular business, essentially every time you shake hands, every time you cough on something, sometimes even if you just breathe on something, you can pass the virus. And so typically you'll have a very explosive curve in terms of the number of cases. It will go up very quickly and then down relatively. The problem with that is that during that period, you will overload your health system capacity. When that happens, every patient that can't access healthcare will die, okay? And that's why physicians and public health people are so aggressive about saying we have to flatten the curve. Now, ultimately, you may get the same number of people infected, but as long as you never exceed health system capacity, then you shouldn't have excess deaths. Okay? Because as I said, when you exceed health system capacity, you need 100 ICU beds, and you only have 40. That means at least 60 people will die for no other reason than they couldn't get ICU care. Right? Whereas if you spread those 100 cases out over a longer period of time and you never exceed ICU capacity, then you're going to still have some deaths because COVID-19 is intrinsically a bad disease, but it'll be a lot fewer deaths because everybody got adequate care. So that's what flattening the curve is. And you really do this by testing, isolating positive cases, contact tracing, and public health measures. And some countries actually managed to stop transmission to a great extent with control measures. So New Zealand did this, Taiwan did this, South Korea did this. They all did very well in the first couple of waves of disease. This involves closing schools, shops, workplaces, bars, restaurants, as well as borders, locking down the borders, and asking people to stay home. Now, we in Canada never went that far, except in the Atlantic provinces. And I showed you what happened in the Atlantic provinces. They had 1/4 the number of cases and 1/4 the number of deaths in the rest of Canada. So it's something we probably should have done. Kind of public health measures we're talking about: hand hygiene, respiratory etiquette, face masks, travel advisories, travel restrictions, border closures, entry and exit, social distancing measures. You're all familiar with this: contact tracing, isolation of sick individuals, quarantine, school measures, workplace measures that you're all familiar with, and then service cleaning and particularly improved ventilation is really important in schools. None of these are 100% effective. Okay? But really what you're doing is you're using a Swiss cheese approach. What you're trying to do is put layers and layers of protection so that ultimately almost everything is blocked. But you've got to be very aggressive. Now we have a new weapon. We have vaccines. Others are going to talk about vaccines in more detail than I will. But there are generally 4 types of vaccines. There are whole virus vaccines. I know there's some older people here. Bet you're all vaccinated with for polio. You probably remember some of the polio pandemics of past years in the 1950s and 60s. Salk came out with a great vaccine. It was a killed virus vaccine. You just took the virus, you inactivated, injected it. Sabin came up with a new vaccine, which was also a whole virus vaccine, but it was a live vaccine, and that was the one you took under your tongue. Great vaccines, but there's no COVID vaccine example at this stage. Then there are viral vector vaccines. So for example, the Ebola vaccine that came out last year is an example of that. There are others that are like that. What they do is they take a defective virus, like an adenovirus, which causes just common colds in humans, and they load it with parts of the COVID-19, the SARS-CoV virus, the part that makes the spike protein. So they give it to you, the virus gets into your body and into your cells, and you basically make the spike protein. But because they didn't give you the whole virus, you only make part of the virus. And so you develop antibodies to the spike protein, and that gives you immunity. So that's an excellent way to go. The Oxford AstraZeneca vaccine, also called COVID Shield in India, is an example of that. Also the, I believe the J&J vaccine is another example of that. There are subunit vaccines where basically you just, for example, take the spike protein, right, and you inject that by itself. It's got no virus attached to it, so it can't hurt you except giving you a bit of an inflammatory response. The Novavax vaccine for COVID-19, which isn't available in Canada, it's like the Russian vaccine, is an example of this. But there are other vaccines of this sort that have been used in humans. Hepatitis B, tetanus, meningococcal vaccines, pneumococcal vaccines, a lot of examples of that. So that's another type of vaccine that's out there. And there's the one vaccine that we've been using most commonly here, which are the mRNA vaccines. mRNA is the kind of the blueprint. Well, if DNA is the blueprint, mRNA is kind of what creates your spike protein. So when you give people mRNA for spike protein, all that happens is it gets taken up into your cells. Your cells say, hey, we have instructions to make a protein, and you make spike protein, basically, is all that happens. These are great vaccines because they're very easy to adapt. So when you get a new variant, for example, you can make a new vaccine in 6 months or less, whereas these other vaccines take years. This is the Pfizer and Moderna vaccine. There's no example in humans, although these kinds of vaccines are actually fairly commonly used these days in animals. There were some vaccines that they were working on, including influenza for humans. And COVID just basically came in before, and we had to create this vaccine for that, but the technology is very well established, and within a couple of years we'll see more of these viral vaccines. What are the common vaccine side effects? The vaccine side effects are exactly what you'd expect. What you're doing is you're inducing an immune response. So the same kind of symptoms you get when you have a common cold, that's essentially what you can get with the vaccine. You get some pain and tenderness, redness, itching in the area of the injection site. You can get some chills and fever. My wife got a fairly robust chills and fever. Headache, myalgia, body aches, arthralgia, joint aches, nausea, vomiting, occasionally diarrhea, pain in the legs or arms, influenza-like symptoms. Sounds horrible, right? By and large, 80% of people won't even have these. And to the extent you get it, it's no worse than a cold for most people. And really all it's telling you is the vaccine is doing its job. That's how the vaccine works. The vaccine basically almost makes you have a fake infection. It's mimicking the infection. It's just not infectious. So you get much the same response. Uncommon things, you can get sweating, decreased appetite, some swelling of your lymph nodes, some itching, dizziness, rash, sometimes abdominal pain. On rare occasions, you can get basically an allergic reaction. You can get a drop in your platelets, capillary leak syndrome, which is when your lungs get wet, Guillain-Barré syndrome. You heard, of course, pericarditis and myocarditis that you get. Now, the thing I want to really emphasize here is that your chance of getting any of these things is far higher as a consequence of natural COVID infection than it is from the vaccine. And something else I need to tell you is that all of you who are not vaccinated, I know most of you are, but what people don't realize is, given the low vaccine uptake in the world, essentially what it means is that if you choose not to be vaccinated, and what you're basically choosing is to get infected. Because mathematically, if 20% of the population doesn't get vaccinated, and that's enough for the virus to circulate, that means mathematically within about 3 years, 95% of people are going to get infected. So unless you plan on being a hermit the rest of your life, you only have 2 choices, vaccine or infection. And I think every one of us can tell you that your odds of doing well are much, much, much better getting vaccinated than getting infected. Okay, I'm going to just show you some data on distribution of COVID-19 cases by ethnicity and vaccination by ethnicity. We've got 10 more minutes. How am I doing for time?
You're fine.
Okay. So you can see here, this is data, most recent data that we have, is you can see the communities, and this is Manitoba data, that where cases occurred. So you can see the African community, about 5.4% of cases. Of course, the white community has the highest number of cases because that's the highest population. The North American indigenous community has quite a number of cases as well, although their population is about half that. So what you generally see here is that the white population is underrepresented in terms of cases. The indigenous community is substantially overrepresented, and actually the Southeast Indian community is also relatively overrepresented for the population. This is data again, Manitoba population by census and number of cases since May of 2020. So again, the white population is 64% of the total population, but only 48% of the cases. The Southeast Asian population is 8% of the population, 4% of the cases. North American indigenous, very much overrepresented. I'm sorry, so we're actually relatively, South Asian, this is what I mean. So South Asian, you can see here, we're about 3% of the population. Southeast Asian is Filipino, Vietnamese, that kind of area. Whereas this is Indian subcontinent. So you can see we represent 8% of the cases, with only 3% of the population. So
Oh.
we are overrepresented
Oh my goodness.
in cases. This is another way of looking at it. Again, infection rate per 1,000 population in Manitoba, Southeast Asian, 146 for 1,000 people. Filipino, 41% per 1,000. North American Indigenous, 31 per 1,000. So again, you can see these are the most overrepresented up here. We are highly overrepresented, as is the African community and the South Asian community. I'm sorry, what is this group? Oops. And if you break it down by male and female breakdown, you see something fairly similar. If you look at South Asian, we are 2% of the female population, 7% of the female cases, 3% of the male population, 9% of cases. So we have about a 2.5 to 3-fold increased risk compared to the white population. Okay? So there are reasons for that, not all of which can be easily handled.
Can I take a picture of the slide?
Yeah, go ahead. Okay, so this was the South Asian, that was, and I'm sorry, that's the Southeast Asian in particular. I'm sorry, we're a bit better, we're down about 1.6-fold. So 8% of the female population, 3% of the cases, 8% of the male population, 4%. So actually, my mistake, we're actually doing relatively well. It's the Filipino community, and some of the Southeastern Asian community, Malaysia, that area, that's doing more poorly. Part of this has to do with where people work, you know, and where they are in the community. So what you can see here is if you're in food manufacturing, for example, you're at higher risk. Service industry, again, a lot of Indians in that area. Transportation, healthcare workers at increased risk. So you know, basically there are certain job types that are particularly high risk, and there are others that are lower risk. So for example, you're retired, you're management, you're a homemaker, those are all relatively lower risk. But as you can imagine, some of the immigrant communities tend to cluster in food manufacturing, service industry, transportation, and healthcare workers as well. Now, if you look at the age distribution of cases, now BIPOC is basically minority groups. That's people of color, I is indigenous, B is black, right? So black, indigenous, and people of color. Basically visible minorities. And what you can see here is that if you look at the distribution of monthly COVID cases, you can see that particularly for the BIPOC community, it's becoming more focused. This is time on this axis here. So early on, the different communities were kind of equally affected. But as time has gone on, the racialized community, as we call it, the BIPOC community, is representing a greater and greater proportion of cases. And that's because they are lagging in vaccination. If you look at age groups, again, what you're going to see here is within the BIPOC community, particularly for young people, right? Even the very young, right? You see the blue is higher, whoops. You see the blue is consistently higher until you get to these older age groups of 50 plus. But anything under 50, the racialized, the minority communities are significantly higher rates of infection for the population. Likely reasons for higher cases and deaths among South Asians: many work in crowded conditions, more transmission, multi-generational homes, which is something that I think is really underappreciated. And then the one thing that we do see is decreased vaccination rates among both the very old, the young and the old. It's interesting though, one thing that I found that was very encouraging is if you look at attitudes towards vaccination, the Southeast Indian group here is actually very positive towards vaccination. So we're about 8%. So if you compare, for example, the Chinese group or the South Asian, 82%, Canada total is about 76%, but South Asians, 82%, Chinese, 79%, Blacks are poor with vaccination, have weaker attitudes towards it. Filipinos are somewhat less than average, but Southeast Asians, 78%, and South Asians, as I mentioned, 82%. So that's really what I wanted to talk about today, and we're going to leave questions to the end of everybody's talks. So if you want to hold questions, we'll proceed to the next talk. Okay? Thank you for your attention.
Alrighty. Next, we'll have Chakraborty come and talk a little bit more about COVID-19 as well. Thank you.
What is the good fight here? I have no idea. I think we had
I couldn't.
full size, huh? Full size. Okay.
Okay. To sit down.
I don't think I need to introduce myself. Most of you know me. And those who do not know me, my name is Amiya Chakraborty, and I work at St. Boniface Hospital. Dr. Anand Kumar, he elegantly kind of gave the overview, very fascinating statistics, and he made my job much easier because there will be a lot of overlap. So I'll start with an anecdote, a few anecdotes, now that I have time to share with you. One of them last Saturday, I was covering as a bed doctor at St. Boniface Hospital, and I got a call around 9:30 about a lady over the phone from Norway House, and she was 66. I don't know her ethnicity, and the doctor who called me saying she has come with just 3 days history of breathlessness, and one common question we ask, how much of oxygen that person is requiring. Around 9 o'clock, when I took the call, the doctor said she is on 9 liters, okay, which is not a good story to start with. And I asked how much, what is her oxygen saturation? And he said it's about 91%, right? So we just found out where is our beds, who is the doctor accepting. Within a couple of hours, I got a call back saying, this lady, we are not sending her to Winnipeg, okay? So instead, she's going to London ICU because she declined, okay? I know only this much. I don't know anything else, but 60-year-old lady requiring that much of oxygen, and it escalated. Her requirement went high, and that's not a good start. Yeah. So that was one anecdote, and that lady was not vaccinated.
Oh.
Okay, and we see it now and then. The people whom we are getting for inpatient treatment, I would say majority, I can't put a number, but I would say 70, 75 or even higher, who are not got even one shot. And the other personal anecdotes, I did not take care of that patient. There's a young girl who tried to resuscitate her dad, and her dad had a sudden cardiac arrest. And obviously he was COVID-19 positive. Maybe he didn't know, maybe the daughter didn't know, but he just arrested. we think it could be from abnormal heart rhythm, and in the process of doing mouth-to-mouth resuscitation, she got COVID. She was young, in her mid-20s, and when I heard the story, kind of sad, her dad already died, and she herself was struggling with what Dr. Kumar showed on ventilators. Okay, so young people do not get COVID, it's just not, or severe COVID, it's just not true. So on those sad note, we'll start, and as I said, he made my job easier. I don't know how many of you can see the slide, but I don't think it matters.
Can this be Zoom? No.
I don't think so.
Okay.
Anyway, sorry for the small font size, but it does not matter, because I'm trying to show certain some of the symptoms what COVID presents, and as Dr. Kumar said, most of it is basically having a flu-like illness, which is basically cough, fever, aches and pains, headache, breathlessness, which is not a good thing, sore throat, and some of those patients also come with GI symptoms, right? We didn't appreciate how much GI symptoms, gastrointestinal symptoms, sorry, I try to avoid some of those abbreviations, diarrhea, having nausea, and loss of smell and taste, which you already mentioned. Those are the most common presentation. I think we didn't appreciate the gastrointestinal symptoms much, and chest pain and pressure, all right? So some of those unusual symptoms, other than respiratory symptoms, include gastrointestinal symptoms, loss of smell and taste we already alluded to, and most of these settle down in about a month's time. But in some people, you can still have it beyond a couple of months or more. Skin changes. Yeah, some of those skin changes, we see people get discolored areas in their toes, fingers, and then much more common in children and young adults. And there are certain other skin rashes which can be associated with COVID. And again, those last for a similar number of days, like 10 to 14 days. Confusion, like delirium, what we call in medical jargon, like disoriented to time, place, or person might be a common thing for the elderlies. And that brings me to another anecdote. One Italian man, he was mid-80s, and he was brought into St. Boniface ER just because he was having high fever and confused. So when the paramedics arrived to bring him to the hospital, they asked him, "Have you been vaccinated?" And this was maybe a month, 6 weeks ago. He stopped talking, okay? He didn't want to discuss anything. When he was in the emergency room, he refused to wear a mask, okay? Saying he has special permission from the province not to wear a mask. And by the way, he was not vaccinated at all. So confusion could be a manifestation of COVID, and also eye problems like having pink eye or conjunctivitis, which is also associated with other respiratory viruses, could be another thing. Now I mentioned some of those skin rashes with COVID. Now on the left, what is showing the toes, in Manitoba, without getting COVID, because we are in a cold condition or environment is cold, we sometimes get as a part of, the cold related injuries, what we call chilblains. But if someone has other symptoms of COVID, we'll associate with this. And then certain other rashes you see in the next picture, like rashes having basically like hives, Some of them could itch, some of them need not be. And in the middle, this one, there is a man admitted with COVID and he got under the armpits certain itchy rash, And we are learning more how COVID can affect skin it's a learning experience for in an everyday basis. COVID shares a lot of things with cold, and now that we are in the winter season, we might find some of us having just simple cold, right? But who has cold or common cold, we will not have this nausea, diarrhea, or vomiting or nausea. Okay? Now, cold people or people who have cold, just the standard cold, infection or cold, when we get loss of taste and smell, often it does happen in the context of stuffy nose. Okay? The rest of the symptoms are basically common. Okay? Like having cough, muscle aches, tiredness, sneezing, sore throat, and so forth. We might get fever, but not as prominently as in COVID. COVID versus flu, okay, or influenza. There again, the loss of smell and taste does not happen much in flu or influenza as much as COVID. Gastrointestinal symptoms might happen, particularly in children in influenza, but not much. So again, for some reason last year we were worried how will be the flu season, but it's a fortunate thing we did not have a great, or we had a quiet flu season last year, because the same principles of isolation, mask, hand washing kind of took care of it, and I'm hopeful that we'll continue the same thing and we'll have a quiet flu season. Some people have seasonal allergy, right? And some of the symptoms of seasonal allergy might overlap with COVID, but people who get seasonal allergy should not have fever, should not have vomiting, diarrhea, and those should not happen, And some of them basically had this allergy before, and they know what to expect when the season comes. So those are easily we can distinguish. Now, COVID is a spectrum, as Dr. Kumar alluded to. At one end, or most of them are basically having very few symptoms or hardly anything. Okay, this is at this end. And the other end, which people who are really critically ill, either requiring ventilator support or support for their falling blood pressure or dialysis, ECMO, you name it, right? And so those are the spectrum. And here is the people who are pre-symptomatic and asymptomatic, right? But we have the potential to transmit diseases across the illness. Okay? So they, without knowing, some of them might be giving us the infection. By the time we are careful, it's just late. So isolation is needed for all of them, right? Testing is same for all of them. Now, initially, this part, viral replication, is the main driver of the illness. And the later part, which we have here, is red area. That's where it's the inflammation. Basically, we get the virus, it goes to the blood, and then from the lungs, it goes to the blood and goes to rest of the organs through the blood. But then our body mounts what you call inflammation, or tries to protect us. In the process, it brings out a lot of mediators, part of protecting the body. And those mediators try to limit the infection. That's their one, or that's the only goal. But in the process, they also injure certain parts of our body. So we do not die, or we do not have problems from the virus itself, but how the body responds to this infection. And there is no way anyone can say, we know we have got a cluster of features in whom it will be severe, we got that. But if you ask individually how I'm going to respond to this virus, we don't have a clue. Because we are all different. Okay, so that's what makes it hard how a young patient, once that patient gets infection, how the body will respond. And if the response is really bad, the lungs will suffer from significant inflammation. Does it make sense?
Mm-hmm.
Yeah.
Not only lungs, all vital organs as well, as you are saying, when
That's correct.
they go into fighting mode.
Yeah. And this is not only in COVID-19. Say I get hepatitis B infection, which is a bad infection for the liver, right? So hepatitis B, if my response, my body's response to hepatitis B is so profound, my liver undergoes total necrosis. B infection, hepatitis B didn't do anything, but my body's response is such that that response made my liver to shrink, and I might die having no liver function. Okay? We do not have that capacity yet to modulate the response.
Oh, okay.
Yeah? So, what are the potential treatments we talk about in the beginning part of the disease process? We are talking about virus being the main driver. So there the role in the blue line or blue area, the antiviral therapy. Yeah? And then later part, when the inflammation is the main focus, we have what we call anti-inflammatory therapy. Okay? Somewhere in the middle, we have what we call antibody-driven therapy. And that's the model we have so far. So, high risk, who are the high risk group of, what the high risk population for significant COVID infection? And Dr. Kumar kind of alluded, older age. Most of them have underlying diseases like heart problems or lung problems. Some of them have dementia, so they cannot think what we should do or she should do. Okay, 80% of deaths are in that age. And we had a certain infection breakdown, right? In the nursing home, you remember last year we had several nursing homes are affected by bad COVID outbreaks. Nursing home residents, most of them can't move, right? So it was very difficult for it to contain that infection. People who have lung problems, like bronchitis, asthma, lung cancer, or other lung diseases. Same thing with the heart disease, diabetes, both type 1 and type 2. Certain cancers or other blood disorders, people who have got weak immune system, right? People who have got various transplants, cancer patients, chronic kidney or liver disease, and certain patients with Down syndrome. So there are a clinical risk group, or clinically we can find out who are likely to have severe COVID. So fortunately, majority do not need admission, which is good, and we can care for them at home, right? And oximeter has become a common household item, right? So what are the warning signs that we need to contact medical personnel if someone has got trouble with breathing, persistent chest pain, confusion, lips blue or face is blue, means they do not have enough of oxygen, or not able to stay awake. Those are basically warning signs. Now, majority do not need admission, which is good. How do we manage it? Well, it's an evolving field, changing all the time. Fair amount of coordination goes between telehealth, respiratory clinics, emergency department, ICU, and internal medicine. So when we find out someone need not be hospitalized, first we'll figure out along the risk stratification where that particular patient falls, okay? Find out, do they have underlying medical issues? Second thing, how long do they have, what kind of symptoms they have, okay? As we say, breathlessness always comes higher in that list of assessment. What timeline, how quickly it's evolving, yeah? Can they go from living room to the toilet? Are they able to sleep at night? Can they go up? Can they go down the stairs or go up the stairs? How far they can go if they're going out, or they're breathless even at rest? There are other things. Are they confused? Are they having trouble when they stand up? All kinds of things go into that discussion. Home setting. Home setting is important. If that particular person lives alone or lives with many families, families are exposed, that particular person certainly needs more help, or if that person is alone, he needs more help. Other social factors will come. So outpatient management basically mostly supportive, like giving painkillers, make sure that they are having rest or they have food to eat. But it is changing now, particularly across the border. We have certain monoclonal antibodies, which are there are several of them, and they